met at the Brompton Hospital. And Adri has started off saying and defining what we mean by complete transposition, which of course is known by a whole host of other names, TGA, DTGA, etc. Basically, usual atrial arrangement or mirror image atrial arrangement with concordant atrioventricular connections and discordant ventriculo-arterial connections. The great arteries tend to arise in parallel, so it could be quite a good clue for, say, in utero diagnosis, but not always. And so we usually, in training of sonographers, we say the loss of spiral relationship between aorta and pulmonary trunk, but with the caveat that it's not always the case. It's a useful hint, but not always complete transposition. So in the fetus, the circulation goes like this. I'm sure you're all familiar with, so this is really no issue. But after birth, there would be an issue when the fetal shunts close off and there's no ventricular septal defect or other communications between right and left heart chambers. I've put up here some figures, but probably not really true in this day and age, but up to 20% of cardiac death in infancy if untreated. And I'm happy to say that I no longer see these sorts of cases that come in the neonatal period to me in the morphology lab with intact ventricular septum and closure of the foramen ovale and ductus. So complete transposition is usually described as a simple form and a complex form. So what do we mean by these terms? Simple, usually referring to intact ventricular septum without any major associated malformations, whereas complex is the basic lesion, but associated with other things. So for example, you may have a simple case here, very evidently right atrium with a fairly closed foramen ovale into right ventricle, no ventricular septal defect, a subaortic infundibulum leading up to the aorta, no associated arch malformation, a ductus that's practically closed, a pulmonary trunk coming from the left ventricle here, so pulmonary mitral fibrous continuity. In this form, there's usually a ventricular septum that is pretty straight up. There's no ventricular septal defect. But even in the simple form, this so-called simple transposition may not be quite so simple. For example, there may be variability in coronary arteries, as already alluded to by the first speaker. Arterial relationships may be variable, and there may be also variability in infundibular morphology. And I'll not go into how best to name the sinuses. I think, in my belief, is that so long as within your group you understand each other, there's really no need to put yourself as a surgeon looking towards the aorta and vice versa. And this is just to take into account the very varied locations of the aorta relative to the pulmonary trunk. So however you describe the origins of the coronary arteries, so be it, whatever goes within your group. So the complex lesions are those, transpositions are those with complicating lesions such as ventricular septal defect, occurring in 40 to 45% of cases, and within that cohort, 75% with malalignment of the outlet septum. There is also subpulmonary obstruction, occurring in about 25% of cases, so termed left ventricular outflow tract obstruction. So there may be subaortic obstruction, and there may be about 5% of cases with associated coarctation or even interruption of the aortic arch. Valvar anomalies may be seen, and so on. So the most common associated malformation then, the ventricular septal defect, the various classifications, and this is the one we tend to use in UK, which is talking about doubly committed juxta-arterial ventricular septal defects, those lacking a muscular ventricular septum, outlet septum there. The malalignment defect that may have a muscular border, so muscular malalignment VSD, or simply muscular trabecular VSDs, or perimembranous VSDs. This particular group very important in terms of the relationship to the atrioventricular conduction bundle for the surgeon going in to fix the perimembranous VSD. Muscular inlet VSD is also related to the atrioventricular conduction bundle, except that the bundle goes anterior-calf-led to the margin of the defect. So we look at some of these heart specimens. So this is complete transposition. See the parallel arrangement of the outflow tracts, aorta, pulmonary trunk, right ventricle, left ventricle, ventricular septum here. Going one slice further back, we can see the offset arrangement between the mitral and the tricuspid valves. Here, the interatrial baffle already put into position there. So when you're at the back of the heart, you don't see the ventricular septal defect. You see quite good the offset arrangement of the atrioventricular valves, except that compared to the normal situation, there's a slightly lesser offsetting than in the normal. But there is a ventricular septal defect. If we look again, see here. That's a perimembranous ventricular septal defect. That's the muscular outlet ventricular septum. Posterior margin formed by the fibrous continuity between mitral and tricuspid valves. Go further back, you've lost that ventricular septal defect. The ventricular septal defect in heart incomplete transposition may be associated with other things. For example, a malalignment of that inlet septum, a rightward deviation of that inlet septum, meaning that it carries with it the connecting atrioventricular node and AV bundle displaced from the regular triangle of Koch position. So very important to realize the deviated inlet septum on account of its anomalous course of the atrioventricular conduction bundle and association with straddling of the tricuspid valve. In this example, we also have a malalignment of the inlet septum with straddling of the tricuspid valve. Here, the attachment to the left ventricle. Here, more in view, and we realize how small that right ventricular chamber is in this particular heart. Now you may have malalignment not of the inlet septum, but of the outlet septum. This is the right ventricular outflow tract to the aorta, no big issues there, but when you look inside the left ventricle, you see this left ventricle here, a bit smaller than the right side, and the outlet septum deviated into that left ventricle. Here's the ventricular septal defect, a perimembranous VSD, but left ventricular outflow tract obstruction caused by the malalignment of the outlet septum. And still imaging shows you here, if you make a cut through that heart, you get this situation where the outlet septum is squeezing the subpulmonary outflow tract. This is the mitral valve, so pulmonary mitral fibrous continuity. Now you may have another example here with a right ventricle here, aorta. Here's ventricular septal defect. Nothing to write home about, is there? Quite high up ventricular septal defect, quite small, I would say. Look inside the left ventricle. Here you begin to see something. Quite a small pulmonary valve already. So pulmonary valve stenosis. From the left ventricle. So look up here. We can actually see the ventricular septal defect. And what it is, we don't see a muscular outlet septum here. That's the aortic valve already. So we have a doubly committed and juxta-arterial VSD with pulmonary valve stenosis. But left ventricular outflow tract stenosis can occur with various substrates. You've just seen just now the pulmonary valve itself. You may have deviation of the outlet septum, which you've already seen, valve stenosis. You may have accessory or aneurysmal tissue tags sitting there. You may have abnormal insertions of the mitral valve to the ventricular septum. You may have a fibrous diaphragm or a tunnel kind of left ventricular outflow tract. And this is an example of subpulmonary obstruction with a septal bulge. Right ventricle, looking fine, intact ventricular septum, but over here, the left ventricle. Very, very narrow outlet, owing to this bulging of the ventricular septum, and also dysplasia of the pulmonary and mitral valve. You may have aneurysmal tissue tags, as I've shown you on the diagram. You may have, for example, a subpulmonary muscular infundibulum, and also added to that anomalous muscle bundle obstructing the outflow tract. In this another example here, we see a ventricular septal defect, we see a subpulmonary fibrous membrane, and also associated in this heart, a cleft of the mitral valve. So you can imagine there are lots and lots of variations available. So, but then if you go to the right side, your right ventricular outflow, what can obstruct that? You may have muscular infundibulum, anomalous muscle bundle, anomalous tension apparatus, or deviated outlet septum with ventricular septal defect. So we look at one of these examples here, the right ventricular outflow tract, and we can already see that malalignment ventricular septal defect with the deviation of the muscular outlet septum to the right side. The left side here, the outflow tract is fine because the obstruction was on the right side. Here, the still image shows the deviated outlet septum obstructing aortic outflow tract, and further upstream, we have coarctation lesion here affecting the aorta. Now you may have coronary arteries, anomalies, as we said earlier on. This is probably the most common pattern of distribution of coronary arteries, although there are lots and lots of variations. So an example here, left coronary artery, circumflex anterior descending, right coronary artery, but there's something else wrong here. Gross commissural malalignment between the aortic valve and the pulmonary valve. An example here showing an intramural course of that origin of the left coronary artery close to a commissure, already disproportion between aortic and pulmonary valves, and also we have an accessory anterior descending coronary artery. In this example, a high takeoff, very high. The high takeoffs tend to be associated with an intramural course in the proximal portion as well. We did some studies onto the origins of the coronary arteries, orthogonal origin in majority, but sometimes you can have tangential and occasionally the intramural courses. What about the leaflets of the new aortic valve, the old pulmonary valve? Leaflet disproportion may occur. You may have a bicuspid or fused leaflets. The depth of sinuses may vary. So not always do you get 3 perfectly formed pulmonary valves to make up your new aorta. In this example, we had fenestrations in the native pulmonary valve, and these are just millimeter dimensions, and you can see how disproportional this particular case is a 7-year-old post-atrial switch. We talked about other anomalies, so there's juxtaposition of the atrial appendages, for example, in addition to valvular malformations. And I would like to take you through some of the surgical morphology that we encounter in our post-mortem series. The atrial switch, I'm not going to encroach upon the next speaker's talk, but simply show you some examples that have had previous surgery. So this is a mustard procedure, or the atrial switch procedure, showing in cross-section the baffle in place, switching the systemic and the pulmonary venous return to the wrong ventricles, as it were. A series of diagrams showing that sort of switch, atrial switch procedure. In this example, here's a gusset enlarging the right atrium. You're opening up the superior vena cava coming in, but no longer able to enter the right side of the atrium. Instead, this is a pulmonary venous pathway passing over that baffle to enter into the right ventricle, with a systemic venous pathway now, superior and inferior vena cava, behind this baffle going to the left ventricle. Not without consequences. Here's long-term venous pathway obstruction. This is a pulmonary venous pathway. To my mind, quite a small aperture, maybe about 5 millimeters at the most, coming into the right atrium. Here's the inferior vena cava, superior vena cava. Quite a narrow superior vena cava pathway as well, and coming to shunting the systemic venous return back to the left side of the heart. You may have the so-called descending kind of procedure, again, a series of diagrams here, but mainly utilizing the patient's own tissues, sort of slicing through the right side of the atrium. We see that interatrial baffle here formed by the right atrial tissues here, and avoiding the sinus node, which tends to be sitting in this corner of the right atrium. Over the longer term, after an atrial switch, you may have a dilated right ventricle. You may also have right ventricular hypertrophy. This is a systemic right ventricle. You may have increasing interstitial fibrosis, and there may be microscars involving that right ventricular myocardium as well. The anatomical correction, which is, of course, the arterial switch, where the two great arteries are transected and then change in position, and then extended if need be, and reimplantation of the coronary arteries. And this is a case that has been 4 years after arterial switch implantation. You see some narrowing neo-intimal formation around the orifices of the coronary arteries. So coronary events during early follow-up has been alluded to in these publications here, fibrointimal thickening at orifices of proximal coronary arteries also may be a concern over time. So I hope I've taken you through a series of heart specimens to review from simple to complex transposition, or DTGA, as you see it, from the native lesion, and some examples of post-surgical